Well, thank you guys so much for coming to our panel on A Decade of Change, the Affordable Care Act and Medicaid in Nevada. I wanted to introduce our panelists first, so we'll start closest to me. This is Dr. Jose Cucalan Calderon. He's the Division Chief of Advocacy and Outreach at Renown Children's Hospital. He's also an Associate Professor of Pediatrics at the University of Nevada, Reno, which I am told should just be called the University of Nevada. I'll let the UNLV folks keep their opinions to themselves. We also have a former Nevada governor and now UNR president, Governor Brian Sandoval. Sorry, I can't ever not put governor in front of your name. And then he was also the first Republican governor to commit his state, Nevada, to expanding Medicaid under the Affordable Care Act. So I'm really looking forward to that discussion. And then, of course, Megan Messerly, who is my predecessor here at the Nevada Independent and now works for Politico covering state health policy. I'm really glad that she could join us today. Before she worked at the Nevada Independent, she was also a politics reporter at the Las Vegas Sun. So please give them a warm round of applause. They traveled pretty far to get here. So just a quick reminder that at the end of the panel, probably 10 to 15 minutes, we will have time for audience questions. If you have them, feel free to raise your hands. We also, I know, have virtual attendees. So just put your questions in the chat and we will try and get to them. And with that, we'll launch in. So I wanted to start first with Brian. You were obviously the first Republican governor to commit your state to expanding Medicaid. And I was curious what that decision-making process was like for you.
Yeah. Thank you, and first and foremost, good morning, and thank you for the opportunity to be here today. And it's interesting, it's allowed me to really do some retrospective in terms of thinking what all went into that decision. And you go back to 2013, and the state of Nevada had the highest amount of uninsured in the United States of America. We were over 23%. We did not cover single childless adults, and the threshold for children was really high, and so there were a lot of children that were being left behind. We, I think at the time, had a little over 200,000 individuals that were covered by Medicaid. Also, we had just been through a mental health crisis in terms of the way that those individuals had been treated, and I had visited a lot of hospitals, and in the emergency rooms, there were over 100 people waiting, and most of them had some mental health issues. So obviously, one of the decisions with regard to opting in was covering those folks. The other piece where the hospitals had an incredibly high amount of uncompensated care that they were providing because a lot of individuals were seeking their care in the emergency room. So that, ultimately there were a lot of political pressure. I mean, you mentioned I was the first Republican governor to opt in. And, I've got a lot of phone calls saying, please don't do this because of Obamacare. And you have to remind yourself of what the political environment was back then. But ultimately, to make a long story short, obviously, we all know how it ended. We decided to opt in, and my understanding is, at least at that time, we went from 200,000 something to 600,000 people that had coverage, and now it's over 900,000. So there are a lot of individuals in the state that have coverage that would not otherwise had it.
Yeah, and I think the statistic is about 1 in 3 people now are covered under Nevada Medicaid, and it's fluctuating a little bit with some of the unwinding that's happening, but we'll get to that a little bit later. One last question for you, and we'll kind of open it up for discussion, is, you were a fierce defender of Medicaid expansion during Congress's efforts to repeal and replace the Affordable Care Act in 2017. It even put you at odds with then Senator Dean Heller. Was that a difficult position for you to take publicly?
Well, it was and it wasn't. Politically, of course, it was difficult because at the time, President Obama had finished his 2 terms and President Trump was the president, and he's the one who campaigned on repeal and replace, and a lot of pressure, again, to encourage Senator Heller to be supportive of that position. But I knew what it had done for our state, and the results spoke for themselves. I mean, I got a call from the president himself, encouraging me to talk to Senator Heller, and essentially the conversation, and he was a gentleman about it, but I said, I have a fiduciary duty to the people of my state, and this is in the best interest of the people of Nevada.
And maybe this is something that Megan can jump in on too, because I mean, obviously you took a stance that was not popular with Republicans. Is this issue a partisan issue? What were those discussions like?
Yeah, it's an interesting question. So, thinking about where we're at with Medicaid expansion, I mean, it's been 13 years since the Affordable Care Act passed. Obviously, Supreme Court decision made Medicaid expansion an option for states. It was originally mandatory. Supreme Court said, no, this has to be something states opt into. So we're here, 13 years post ACA, and 40 states and DC have adopted Medicaid expansion. So that's a lot. A lot of Republican states, Democratic-controlled states have adopted expansion, but 10 have not. And I think that kind of speaks to where the politics still is on this issue. This is still hard for a lot of Republicans. A lot of Republicans still don't support this. Most recently this year, we saw North Carolina expand Medicaid. Starting December 1st, 600,000 people will be covered in the state of North Carolina. That was a long political battle. They have a Democratic governor, Roy Cooper. He has been a proponent of Medicaid expansion since he took office, has been trying to get this done. But it took a long time to get it done in North Carolina. And there was a lot of opposition among the state's Republican-controlled legislature. They have a Republican supermajority legislature now. But I've talked to the Senate leaders there, and they sort of came around to this idea. They said, at first we were opposed. There's sort of feelings that these folks should have jobs or what have you, some of the traditional arguments you hear against Medicaid. But then when they really dug into the numbers and realized what it would mean for their state, what it would mean for hospitals and uncompensated care, they came around to this idea that we might have been opposed to this on sort of ideological reasons, but it really makes sense in a practical sense for our state. And so they came around to it. But then it was still this battle to get it across the finish line because there's North Carolina once went like 2 years without a state budget because of clashes between the governor and the legislature. So it sort of became this, kind of got caught in the middle of a lot of conversations. But they finally got it done this year. Legislature just passed a budget, and so that policy will finally take effect. But you think about where other states are at on this issue, and they're not there yet, right? Texas, Florida, two of the biggest states, have not adopted Medicaid expansion. In the Mississippi governor's race right now, Tate Reeves is running for re-election. He's a Republican. He's running against Elvis's second cousin, Brandon Presley, a Democrat, who's like running on Medicaid expansion. And it's become a real central point of that campaign because there is a lot of public support for Medicaid expansion, but there's still this, whether it's, feelings about the Medicaid program, feelings that this was established as part of the Affordable Care Act or Obamacare, right? There's still a lot of feelings around that, but I think you are generally seeing some of the political attitudes, change with time.
And Dr. Jose Cucalan-Calderon, you obviously work with Medicaid and non-Medicaid patients. You work in Renown, and you were associate professor of pediatrics. What do you see on the ground that Medicaid expansion has done? How does it shift our healthcare system?
It is an investment in people. Giving people, prioritizing primary care access as well as preventive care is an investment in people's well-being, family well-being, as well as access to resources that otherwise probably wouldn't be in place. Numbers-wise, we have close to the number of, so the children in the state that are covered by Medicaid are almost the size of, in numbers are the size of the city of Reno right now. So having a whole city of children getting coverage where you have a clear pathway to stay healthy and learn about health prevention and be able to go through the issue is one of the best ways of being able to ensure their future. There is a direct link between high quality care and insurance, and I am happy that we are able to do that right now.
And then kind of broadening this out, I'm curious how kind of Medicaid expansion helped Nevada weather the pandemic, and I don't know if any of the three of you want to jump at that question, and kind of what the lasting effect of expansion is on public health care in this state in particular.
I'm happy to start with that. I would say a couple of things. I mean, when you hear folks talk about, why Medicaid is important, whether we're talking specifically about expansion or expanding new benefits or raising eligibility thresholds or things like that, it all comes back to where where folks are getting their care, right? Are they waiting till things get so bad they're going to the ER, right, and getting at sort of like the highest level, highest cost point of care, which one is both expensive and two isn't great for them and their healthcare. And so, you know, you hear folks talk about why Medicaid is important, and it's important because people then can go to their regular doctor's visits, they can take their children to get their vaccines. It's sort of that extra incentive knowing that when I go in to see the doctor, I'm not gonna get this really expensive medical bill. And obviously there's other ways of getting care. You know, in the US we have federally qualified health centers, which offer services on a sliding fee scale. That can be really helpful for folks who don't have insurance, but it's sort of that peace of mind knowing that when you go to the doctor, you're going to be able to get coverage. And so I think at a basic level, it encourages folks to get sort of preventative care, keep their health in check. And as we know during the pandemic, you know, folks with underlying conditions were at much higher risk, right, for complications because of COVID. So I would say, you know, that's a big one. And then we think about broader public health as well. You know, like vaccinations, things like that, right? It sort of encourages folks to stay on top of their health and sort of get that care, so they're not waiting till, you know, they have all these complications. You know, they're getting their, you know, diabetes caught early and managed, hypertension, things that are very everyday but very important, can have very serious health consequences if you're not managing those conditions.
Oh, yeah.
And I'll jump in. I mean, there's no doubt that it's been a benefit to the state, and as Megan said, the coverage that individuals are receiving has been so beneficial. I think if there's a challenge, it's because there aren't enough physicians taking Medicaid patients, and that has to do with the reimbursement. So it's great that you're eligible to go to doctor, but then you have to wait 2-3 months to get an appointment. And so, you know, I think that's one of the challenges of now, is to increase those reimbursements so that more physicians are willing to take Medicaid patients.
You're nodding.
Well, yeah, that's my day-to-day. I was the only Medicaid exclusive pediatrician who spoke Spanish and who is a native Spanish speaker in all of Northern Nevada for 5 years. That changed recently. And during that amount of time, being able to, for us to provide a medical home and be able to do preventive care plans definitely worked out of our office. But then a lot of times we just didn't have people to work with, or we had to send a lot of our patients out of state to be able to get care, when being able to have local support would have made more sense. And then on the strategy part from the medical plan itself is that also thinking about the experience for the patient is also a little bit better, a better tally of how to be able to consider delivering care for them. A common example that I have is that in one of the Medicaid MCOs, I have to send people to Las Vegas to get seen by an ENT all the time, where they are paying for travel, they're paying stay, they are having just like disrupting their whole day of activities for them to be able to go and see a medical appointment, because that plan doesn't have a contract and is not negotiating with the people that we locally have in Northern Nevada.
Right.
For X, Y, or Z reason, that's not my part. But the part that where families talk to us and they ask us for alternatives all the time because the care that they are receiving is just too difficult to be able to access or for it to be successful in carrying out a plan, also can get in the way.
So, if, you know, we're talking about this provider shortage, we're talking about a lack of access to pediatricians or doctors who can't speak Spanish. What are solutions that are being discussed, or kind of where's the discussion going with where do we go next?
You know, I can jump in. There are a couple things that I think can be done, and one is expanding graduate medical education and putting more funding into that. And that's something that we did while I was governor, but it gives the ability to have more residencies in the state of Nevada, and there's great statistics that residents will stay 70% of the time where they've done their residency. So that's one thing that can be done. And then being a little parochial with regard to the University of Nevada School of Medicine, by virtue of the university's School of Medicine's affiliation with Renown, it makes the University in Renown eligible to apply for more Medicaid funds. So it's called the upper payment limit, but essentially we put more money in, we get more money back from Medicaid, and one of the benefits of that is we can increase the reimbursements for the Medicaid providers.
And Megan, is there anything that other states are doing that you've noticed or you think is kind of interesting?
Yeah, there's a couple things I would point out. I mean, specific on the Medicaid front, I think it's very important to note that there's not enough providers. Often providers will say, those reimbursement rates make it really difficult for them to, keep, especially if you're, say a solo practitioner trying to, take Medicaid and balance your practice. It's really hard for folks to be able to do that given the reimbursement rates. That's obviously a very important part of the conversation. I would say there's a few things that states are doing to sort of further expand coverage to folks. Again, thinking about sort of the promise of the Affordable Care Act and making sure everyone has insurance. And again, there's a very valid conversation to have about, okay, once you have that insurance, can you use that insurance? Where can you go? And what is it going to cost you to use that insurance? But just thinking about getting people that basic level of coverage. There was this part of the Affordable Care Act that not many states actually opted into, known as the Basic Health Program. And some states have been looking at this. So it basically creates something on top of Medicaid. Medicaid for childless adults goes to 138% of the federal poverty level. Basic Health Program takes that to 200%. So it captures the people in that group right. Again, we're not talking about people who are making a lot of money. These are still fairly low income folks. But a lot of states did not take advantage of this. I mean, there was certainly a lot going on when the Affordable Care Act was taking effect, from setting up state health insurance exchanges to adopting Medicaid expansion. So not many states opted into this. New York State, for example, has the Essential Plan. They've done this. More and more states are looking at adopting a basic health program. I'd even talked to people, a lawmaker in West Virginia, a very Republican-controlled state, looking at a basic health program. Kentucky had looked at one. So this is something that I think states are eyeing to say, like, we know that care isn't affordable for folks in that range. Like, what can we do to help them? So I think that's one potentially, really interesting solution. We've also seen, I would say, states look at how to add new services under Medicaid. There's some interesting things states can do with waivers. So basically, states tell the federal government, Centers for Medicare and Medicaid Services, and say, hey, we want to add this new service. There's this requirement that it, is sort of budget neutral to the federal government, so they're saving money in some ways, but providing an extra service. And states have really been sort of tinkering around the edges, and under the Biden administration, they've sort of expressed a lot of interest in adding services for what we're now calling health-related social needs, previously social determinants of health, doing things that are sort of around health, but not necessarily what we would think of as traditional healthcare to support people, whether that's, housing insecurity, food, things like that. And so states are looking at doing some things with that, especially, I'd say on the coast, some of those states like Oregon, Washington, California. And then a lot of states are also looking at how to support the justice-involved population. How do you have that transition of care, from leaving the justice system, leaving incarceration, and getting those supports you need, whether it's substance use disorder or things like that. So there's some really interesting work happening around that. So I think we're seeing states find ways of sort of filling in some of the gaps, looking at, okay, we've taken a lot of great steps over the last decade, but obviously we have a lot more to do. And so, what can we do sort of within the confines of the Medicaid program and under what Congress has given us authority to do to make coverage more accessible and affordable to folks.
Well, and there's also federal money available to states that are trying more and new and innovative approaches, right? Which, like, you talked about getting the state more money when you were governor, Brian. Is there anything else that, obviously here in Nevada, we're considering the public option, which could theoretically bring in up to $500 million over 5 years, I think, are some of the estimates. Do we think that those types of solutions are what we need to be going toward, or what are the broader things that state lawmakers should be considering that they may not have considered?
Do you want me to
looking
jump
at you,
in?
Megan, but also...
Well, and I was just going to follow up on something that Megan had talked about in terms of waivers. And one of the things that we did is, as I mentioned, with regard to childless adults, we made them eligible, and that really was part of the expansion. But for mental health patients, the amount of the reimbursement wasn't sufficient, so it wasn't opening any private beds. And so all of the state beds had been taken, so there was still a lot of individuals out there that weren't getting the care that we needed. So we and I negotiated directly with the Secretary of Health and Human Services to increase that daily rate, and that added hundreds of beds. So that was one way that the state could, provide more services and a really good relationship with the federal government.
Right.
I'm happy to jump in on the public option a little bit. And I think this gets to kind of the other part of the conversation we're having, which is, okay, folks have coverage, but is that coverage, affordable to them? And this is one of the things that states have been trying to do with the public option. So looking at states like Washington, which was the first state to adopt it, Colorado, which is well in the process of having theirs underway. And some of the goal there really is aimed at driving down costs, right? What these states have done is say, like, let's take Colorado, for instance, and this is how Nevada's legislation is structured too, but there's these cost reduction targets, right, that plans are supposed to meet. In Nevada, Medicaid MCOs are, supposed to submit plans, and then eventually, the goal is to drive down those costs. So it's a lever that the state can pull to sort of try to rein in healthcare spending, and I think this is something that states are really interested in. At the federal level, folks are really interested in, but hard to get Congress to agree and get things done. They narrowly averted a government shutdown, so this is, really challenging. But states have been really looking at, okay, once we sort of fill in the cracks, right, and we sort of feel like we've covered people and reduced our uninsured rate, how do we actually make that care affordable to folks? And this is one of the ways that Nevada and other states are trying to do that by saying, like, can we offer a cheaper plan, right? The state health insurance exchanges exist, but, a lot of people, especially if they're making quite a bit of money, those plans can be really unaffordable for folks. They often come with, high deductibles. It can be hard for folks to feel like that's affordable coverage. They have coverage, but can they really use it? Are they sort of afraid to go to the doctor? And so I think that's something that states are really looking at. And then one thing I didn't mention earlier, which is particularly relevant in Nevada, that other states are doing, is looking at how to expand health insurance to their undocumented populations. That cannot be done with federal dollars. Federal money cannot go toward paying for Medicaid for undocumented folks, but states can use their own funds to do that. It's obviously very expensive because you're not getting any federal match. Your 60 whatever percent you'd be getting for the traditional population, 90 whatever for the expansion population. You're not getting any of that. You're paying for that solely out of pocket. But a lot of states have been moving that direction. Filling in some of the gaps. Oregon, Illinois have taken this incremental approach where they expanded coverage to some folks, and then they've been gradually, from children up and then from elderly folks down, trying to get to full coverage. But I think that's another thing that states are sort of looking into, realizing that at least if we're talking about reducing the uninsured rate, that's a big chunk of the population for a lot of states.
And Dr. Kuklon, you work with a lot of Medicaid populations, a lot of Hispanic, Latino populations. Can you speak to this issue of uninsured populations and what
Absolutely.
They're looking for?
So I see right now, again, I'm a pediatrician, so I see children, but I do have to say that it is very common, where it is a very common occurrence in practice, that I am talking to parents about accessing healthcare for any issues that they might have. And normally the conversation goes, the way that it goes is that I end up getting told that they don't know where to go, they don't know how to access care, they don't know if they want their names on a list, they don't know if they want to apply for WIC sometimes, they don't know if they are going to agree to be able to have their children being evaluated by early intervention of Nevada because of a speech delay or different things, and that's normally my interaction with them. We end up giving them information in a way that mostly spoken, but I generally have information available for them to be able to look at places where they can seek care for whatever is going on. I can tell you that the common trend is that parents of my patients are not accessing preventive health services, probably 90% of the time. And part of the barrier is not knowing, part of the other barrier is the fact that in Latin American cultures, preventive care is just something that just is not the way that the healthcare system is structured in a lot of places where people come from. So that also is something that people have to learn. It's a good idea for me to go and have my blood pressure checked every year. It's okay for me to go and get seen by somebody to manage my diabetes. I need to get a pap smear, I need to get a mammogram. And like those things you just don't see in a lot of in different places in Latin America. The more rural the families are, the less likely that is to happen also.
And so what are strategies that people could take to reach these communities?
So as the National Hispanic Medical Association, that is one of the state, that is one of the things that we have been doing, is prioritizing preventive health information and being able to deliver it in a way that can reach him. So Telemundo Reno has a recurrent cycle of health-related news where both Dr. Maria Fernandez and myself take different spots, and we start talking to communities about just preventive care and about things that might be a good thing to choose for. Right. We also have, we are doing multiple other media appearances other than Telemundo. We are doing, we are right now rebranding it, but through the American Academy of Pediatrics, we were having a walk with a dog session that was all in Spanish and all geared towards preventive health in children that I am happy to have initiated and collaborated on. We are right now changing the name and going to relaunch it with something with the same idea, but as something a little different. Then the most health districts have outgoing communication in both languages, in Spanish and English at the very least. And the people who are working in those positions are people who are Latinas, probably even native Spanish speakers, who are doing a lot of this outreach and trying to get communities in a way that from a trusted source, from somebody who they consider as reliable person giving them information, for them to be able to get this information and then utilize it to their benefit.
Do you guys have anything else to add about this, or?
You know, and I'm not in this anymore, but with regard to the public option, and theoretically, you require less expense, less charge for the service, but you also have to consider that then there's some cost shifting that goes on with regard to private insurance, and then the hospitals will cost shift to the patients that have the private insurance, which in turn drives up their premiums. So there's always, it's like a balloon. You push in one place, it's going to push out on another.
Go ahead.
I was going to say, I feel like this is one of the broader challenges of the American healthcare system, right? Is we cover people in all these different ways, right? You have some people in the public option, you have some people on Medicaid, and I would say there's different kinds of Medicaid, right? Whether we're talking about, what qualifies you for Medicaid or Medicaid MCO versus fee-for-service, there's Medicare, there's TRICARE, there's the VA, there's whatever private employer-sponsored insurance. And so from like a provider perspective, right, you're trying to balance all those different rates, knowing I get paid this by this provider, and trying to sort of make that work, and it's very complicated,
Well, and one thing that is really complicated about that is also keeping track of what you can do for each person at each time, every time that each one of those panels actually changes, because there is a rotating door of changes happening every year.
No, and last thing I'll say is there's a lot of pressure on these physicians, and they're being measured by how much time they spend with each patient, and they're looked at how many patients they're serving each day. So that doesn't give a lot of one-on-one time with the patient.
Right.
Absolutely. That's completely true.
And it's hard to probably diagnose too, or help with certain issues given time.
Well, the training that I received and the time my timeline of working here in the United States has allowed me to find ways of being able to comfortably do that and hit all consistently all of the time, the patient's needs, and thankfully the quality criteria as well. But having the time to be able to talk to the family, to each parent about their kid's health and their well-being, which will include parental health as well every single time. If you have a caretaker who is not well themselves, or who is too sick to care for their kid or be able to go to work and provide for their children, then that is something that a pediatrician should be able to address. And this is something that we are trying to teach. This is something that we're trying to show by example. This is something that we're trying to actively talk about, because all of this is considered preventive health anyway.
Right.
And being a resource for our families.
And we've talked about kind of the financial stress on families. I mean, across the board. I don't even think it's just relegated to Medicaid or Medicare patients. Right now we're seeing rising inflation, and I wanted to talk about how that touches as it's happening when we're unwinding. And for those who don't know, Nevada, like a lot of other states, is in the process of reviewing whether its Medicaid recipients who remained enrolled in the program during the pandemic are still eligible for coverage. And so already we're seeing reporting from KFF indicating that more than 169,000 Nevadans have been removed from Medicaid. What ripple effects is that going to have at a time when we're seeing rising costs of healthcare?
I'm happy to start out and kind of just set the stage for unwinding, and then y'all can chime in on sort of some of the practical effects. I mean, there's sort of this push and pull when you talk to folks, about unwinding and the consequences. On one hand, you have states that have been told since the pandemic by Congress that, hey, we'll give you extra federal dollars, but you must keep everyone enrolled. And that was true until earlier this year, April 1, states could start disenrolling people. So on one hand, that kept people covered during a very difficult health event, gave people coverage, gave people peace of mind that they would remain covered, regardless of whatever fluctuations we were seeing with jobs and stay-at-home orders and all of that. So it gave people a lot of assurances when it came to health coverage. On one hand, though, you think from the state perspective, and this is where a lot of states have wanted to move quickly through this process, is states are paying dollars for those folks, some of whom, we don't know exactly how many, but some of whom are no longer eligible for the program. They may have employer-sponsored health insurance. When you're thinking about a state that has Medicaid managed care, they are paying a capitated rate to cover these folks who are no longer eligible. So this is a significant financial cost to states. So some states have wanted to move through this process very quickly. On the flip side, one of the sort of benefits of this continuous coverage provision is that folks have remained continuously covered. When we talk about Medicaid, there's a lot of this churn that happens, right? It's complicated, there's paperwork, folks need to show what their income is, prove they're still eligible. This just kept people covered across the board. And so in some ways that was really helpful to have that sort of continuity of coverage, but it was expensive. And so now we're seeing states sort of work through this process, whether they're taking, the federal government has urged states to take 12 months. Some states are just sort of going through that process, doing their normal monthly renewals as they would have done pre-pandemic. Others, have prioritized people they believe to be likely ineligible. But, sort of regardless your thoughts and philosophy on that, people are losing coverage. And so the conversation now is, where are those folks going, right? You can see the raw totals of how many people in Nevada and elsewhere have lost coverage. The question is, are those folks going to employer-sponsored coverage? Have they, they're in Medicare, they have other coverage? Or are those folks going uninsured? And how do we make sure, if we lose those folks, how do we get them back?
And, did you?
No, again, I'm not there. I just know some things anecdotally, and Megan did an excellent job of kind of covering this, but there are a lot of individuals that are dually enrolled in California and Nevada. And so, this is an exercise that has to happen, we're all hopeful that if those that are otherwise still eligible will still continue to have coverage, but at the same time, that's a margin of money that you could continue to invest in the Medicaid program that we otherwise can't do.
Right, and it's kind of vital that folks are insured, and so do they qualify for Medicaid? If not, can the state's health insurance program or the HealthLink program kind of catch them and help them find another option?
I can tell you that I had a lot of patients cancel. Over the last 3 months, I have had a lot of patients cancel their appointments.
Is it because they were
because
disenrolled?
they just didn't, so either they filled it incorrectly, they didn't understand what the paperwork was, or they just had to deal with 3 jobs and 5 kids and not being able to put things on time. So there are going to be multiple barriers other than those, but what's the word?
The documents.
Documentation is necessary, but it shouldn't be what we hold medical care to a standard only. We probably need to, right now, one of the big things that should be a big investment in people is going to be trying to be able to help them if they continue to qualify, to be able to bring them back. And then if they don't qualify, help them find ways of being able to continue securing their care. You end up being one of these families and your child ends up getting diagnosed with cancer during this period of time, and what are you going to do?
And I would just jump in here. I mean, what we're talking about here are folks usually who've lost coverage. We call it like procedural disenrollments or people who've lost coverage for administrative reasons. In an ideal world, every state Medicaid agency would have all the information and be able to make a yes or no determination, right? That's best case scenario. But in a lot of cases, this isn't just true with Medicaid, I think it's true with all of us in our healthcare experiences. It's very complicated and very hard. In a lot of these cases, people are trying, I've talked to people who have just had trouble, tracking down paperwork. So I talked to someone who, worked at McDonald's, and for whatever reason, the state was pulling in information saying she still worked there, and she was like, no, I didn't, and then had to go track down, and McDonald's corporate took forever to get back to her. There's people who have sort of made good faith efforts to try to get the information in, and yet have failed to do that. And then there's other people, like we're talking about, who missed a notice in the mail. They've, changed addresses. I talked to someone else in another state who, had told her state Medicaid agency, I've moved, yes, I've really moved, and they kept sending letters to her old addresses. So there are people who are falling through the cracks, and so the goal here is like that balance between how do we move through this process efficiently to remove the people who are actually ineligible, but not move so fast that we lose so many of those other people who are losing coverage sort of for, accidental reasons.
Yeah. And just to let the audience know, we have a little bit under 10 minutes left, so if you do have questions, please bring them up, and we'll open it up now for audience questions, both online and in person. And see, we already have a question back there, so.
So recently there was a report that life expectancy is greater in blue states than it is in red states. And so I think this is a question primarily for Megan. What's happening in the states that report is going to affect Medicare coverage in those states that don't have it?
That's interesting. I'm trying to think about some of the reasons why life expectancy, might be different in those states. There's a lot of different factors that go into that. If we're talking about just Medicaid specifically, which I think is kind of what you're talking about there in terms of benefits, I think we have seen, broadly speaking, blue states sort of try some of these more innovative measures, trying to identify, again, things that maybe aren't traditional health-related services, right? But, okay, how do we cover that? We realize our population has an issue with, whatever it is. How do we get that service covered? But I will say, I feel like there are a lot of red states who are trying really interesting things. Like, one that comes to mind is Indiana. This isn't with Medicaid, but they've really done a lot on public health, and they've really tried to move the needle, especially in the wake of the pandemic and some of the mistrust of public health. They made this massive investment into really building up public health at the county level, sort of empowering, county health departments to be able to sort of make decisions, sort of know what the biggest issues are in their community, whether we're talking about, obesity or smoking or things like that. So I think there is some movement on that in red states as well, but I think in general we sort of just see different, attitudes, at least toward policy solutions. In a lot of red states, we see a lot of emphasis on, personal responsibility, things like that, whereas in blue states, you've seen a lot of sort of focus on, government programs and more spending. But I think it's an interesting philosophical question that I think both red and blue states are grappling with.
Good morning. I had a conversation with Governor Kenny Gwinn once, and he mentioned that sometimes we may be a little short-sighted in that we say no to a federal program, where if we said yes to it, we would have to pick up 25% of the cost and the feds would pick up 75%. But if we say no, we have to pick up 100% of the cost. So are there any things like you talked about, the basic health care or other programs that we're currently saying no to, that we're picking up 100% of the cost, versus if we were to participate in those federal programs, it would cost us less on a state level?
I'm happy to start with that. I think one of the things there is there's things that every state is not doing, right? Like, there's a lot of different solutions I think that people are trying. But I think the problem is that it's not so simple as that. Like, you have to look at some of the knock-on effects, like the cost down the line. You think about, okay, we're providing this service, and yeah, maybe we have to make an investment up here, but it'll save us money down the road. And in a lot of ways, I think those are intangible things. It's helping people's health down the road, which has like an economic benefit. It has, a benefit to hospitals in terms of not providing that high cost care. But a lot of times I think it's it's just, there's like not a one-to-one correlation with states where you're able to say like, okay, we're putting in 20% here and that's gonna save us money down the road. What I will say with these waivers though is that the goal is supposed to be that it's budget neutral to the federal government. And so the goal with a lot of these programs is that you are saving spending somewhere by adding this service. Maybe you're making an upfront investment, but the goal is that it's budget neutral and you're not spending in the long run. But in terms of like specific things that states are missing out on, I mean, there's so many options, different services you can cover. Again, states can work with CMS to sort of design new programs that they're interested in implementing. And so I think it's hard to say whether there's like one specific thing or a few specific things that some states are missing out on.
Yeah, go ahead.
No, and I just briefly, and I can only point to what the situation was in 2013. Federal government comes to us and says, these newly eligibles, we're going to cover 100%. But over, I think it was a 5-year period, it was going to be 90%. And so to the state, that was a lot of money. And at the time, we had a $2 billion budget deficit. So we were, really taking somewhat of a risk physically in terms of where are we going to find this money as things go on. And fortunately, the economy improved. But it did all the things that Megan talked about. I mean, there was so much uncompensated care, and it literally brought billions of dollars to the state. And that was one of the questions that present. Why wouldn't we, if this is available to us, why would we do this and help so many people?
And one of the comments that we've seen on the chat was more providers would accept Medicaid if reimbursements were faster. I mean, you've worked in government. What is one way that we could speed up that process? Because I have friends who are on Medicaid, and I mean, most of us probably know someone, given that 1 in 3 Nevadans are on Medicaid, and they aren't covered, and we've talked about the provider shortage. So I'm wondering, can we talk about some of the challenges that are presented with the existing system that we have and some solutions to that?
Yeah, and again, it's been a little while, but it's people and technology. I mean, and if the providers aren't getting reimbursed on time, it's stretching them. And so, I suppose there needs to be a deep dive into what that process is and what the investment it will take to put into that.
One thing I would just add is it would probably be shocking to you how many of these systems are really antiquated. Like, we're used to in an urban area, suburban area, you can order whatever off of Amazon and it's here tomorrow, and the internet follows you around. You've looked at one thing and now it's everywhere. We're so used to technology working a certain way because it does work in our daily lives most of the time. With Medicaid, things are like decades behind. Things that you would think would be a simple fix. A good example is, and this is actually a good example of something not all states have opted into, though most of them now have. There was an option to cover postpartum folks up to 12 months after birth instead of 60 days. A lot of states have opted into that. There's a big conversation right now in Texas. Texas opted into that, but there's folks in the meantime who are losing coverage in unwinding who will be eligible again, but that that has not yet been implemented. And you would think like, oh, okay, just go into the system and just change it from 60 days to 12 months, but it does not work that way. I mean, states all have contractors for their Medicaid systems, the Deloittes and such of the world, and it's like a months-long project to make one coding fix. I think when we think about the technological challenges with Medicaid, there are so many, and it's because so many of these systems are so old, and even changes we would think might be really simple are extremely complicated.
On the provider side, the other thing that is important is that the timeliness of things also, and the fact that we have to do a lot of searching around. So I end up speaking to insurances all the time, trying to be able to get care for my patients. And the way that each one of the MCOs works and carries their patient panel is different. It's completely different. So and then there are 4 different plans, and then they change twice, and then you end up having days where you have to where you're seeing patients from any of the different MCO Medicaids, and you have, I don't know, 10 prior authorizations that you have to put in for medication, and each one of them has a different way of being able to put prior authorizations, and then they change it twice a year.
Right. And so it's hard for doctors to keep up.
It's really difficult to keep up, and it's a really large time-consuming thing, because this delays patient care as well. and our patients don't get their prescribed treatment on time either. So a lot of an area of improvement over time definitely will be being able to agilize not only the enrollment, but also the way that we are able to deliver care and receive payment, of course. But the specific things that affect care can also be due to the same reasons that Megan was explaining.
And I know we have about 40 seconds left. The clock is ticking at me. So I wanted to just, if there's any last things that you guys would like to say or just some notes briefly, that would be appreciated, but also no worries if you don't want to add anything else. Megan?
Yeah, I would just say, I mean, I think there's a lot that states are trying to do to tinker on the edges, not that the federal government is as well, but, you know, people like to say the states are the laboratories of democracy, right? And I think we are seeing states try to do a lot on healthcare. And so, you know, as doom and gloom as healthcare feels sometimes, there are solutions out there, and states are going to try them out and sort of see what works. And often the federal government takes lessons from the states.
No, I'm really proud of the state and where we were 10 years ago and where we are now. There are hundreds of thousands of people that have better health care and quality of life because of what was done, the expansion.
And coming together and finding solutions together, no matter who you are, where you come from, and where you stand, is definitely necessary to be able to improve the process, no matter what that process is. When we're looking at healthcare, process improvement is a big part of improving also patient outcomes.
Absolutely. Well, thank you guys so much for joining us today, and stay tuned for our next panel on affordable housing. So.
Thank you.